Okay. Good evening, everyone. My name is Armand Kotikian. I am the past president for the Armenian American Medical Society, practicing oral surgeon and the chair of the continuing dental education, and also part of the continuing medical education committee for the Armenian American Medical Society. I'd like to welcome all of you. I see a lot of familiar names under the participants and a lot of new ones. So welcome to the new ones. We have a wonderful evening scheduled. Some three great speakers from the University of Southern California. Before I introduce them and introduce the topic, I wanted to kind of do a little housekeeping. Just want to remind everyone that the Glendale Health Festival is coming up November 4th, which we've had every year now, as you all know. It's taking place November 4th. It'll be all day. We are looking for dentists. So if you are free that weekend, we'd love for you to join us. Even if it's half a day or all day, even better. Please go to glendalehhealthfestival.org or .com. I have to double check websites. Yeah, it's right there. And just register, and we'd love for you to join us and help the community. This is the beginning of some series of lectures we're going to be having with University of Southern California. This is the first one. We have another one scheduled via Zoom October 17th as well. And we will be having an in-person one at Phoenicia October 25th on opioids, which we all know is a requirement now with the dental board. At the conclusion of this course, you will be receiving 2 CDE and or 2 CME credits. Please listen for the secret word that the presenters will at some point tell you what those words are, because it will be required to get the CDE credit. Tonight's talk is going to be on what are myogenous conditions and how are they treated. We have 3 wonderful speakers, which I'm going to have them introduce themselves as far as their education, because each CV is about 5 to 10 pages. Our first speaker is Dr. Padilla, who has been here with us before. Our next speaker is Dr. Davoudi, Jouliana Davoudi, and Dr. Ahmadieh. I hope I pronounced it correctly. I double checked with her. So without further ado, I'm going to hand over
Dr.
the talk
Padilla.
to all 3. Welcome.
Thank you very much for the invitation, and thank you to the Armenian American Medical Society for having us here. This is a team that we have been working together, creating some academic experiences and continuing education classes. So it is an honor for the 3 of us to be here, sharing with you some of the things that we have been up to. We have decided to do today a little bit back and forth. So it's not going to be exactly in order, one after the other, but we're going to be jumping, and we have a program that we are very, very confident that you will enjoy it. First, let me say hi to everybody on the group over here. We see a lot of familiar names. We even have someone from Tokyo, visiting from Tokyo. And we also want to say hi to whoever is following us in social media. This is a Facebook Live as well. So we are all over the world probably trying to, spread the word of some of the conditions that we can treat. We do believe that it's our responsibility to provide relief to our patients. And we do believe that one way to do that is through education. And that's why we're here. So I'm Mariela Padilla. I'm the director of the Advanced Orofacial Pain Program at the University of Southern California. I'm a diplomate of the American Board of Orofacial Pain and fellow of the American Academy of Orofacial Pain. I'm also the Associate Dean of Strategic Planning and Outcomes Assessment at Hermanos School of Dentistry. And I am very, very, very happy to be here sharing with you. I'm going to allow my partners to introduce them, and then I will just take over with the first part of the topic. Dr. Jouliana, what about we continue with you?
Hello, everyone, and I'm honored to be here, and thank you, everyone, to participate in our lectures. I'm very excited. So as Dr. Padilla mentioned, we are a group that we are trying to be kind of work together and kind of spread the word of the orofacial pain and how to treat it, how to help the patients. And my education as well as goes, I'm a US graduate from Trojan, proud of it. And I did residency at USC for orofacial pain. And I'm a diplomate in American Academy of Dental Sleep Apnea. And also I do lectures for the sleep apnea, especially for dentists and medical fields. Welcome everyone. Thank you.
Thank you. What about you, Dr. Ahmadieh?
Hello, everyone. Welcome. And it's great to have you all here. Thank you so much for having us tonight for this lecture. It's a pleasure for all of us to be here. And a little bit about my background. I have done my residency in oral medicine and orofacial pain at USC. And then I joined the faculty at USC. And currently I am associate professor at USC Dental School. And I'm also the diplomate of the American Academy of Orofacial Pain and fellow of the American Academy of Orofacial Pain. So thank you so much. I hope you enjoy the lectures.
We forgot to mention that none of us had any disclosure or financial interest on this activity, and we're not getting paid. We're here because we really believe in education, and there is no disclosures or any commercial disclosures from us. So we forgot to say that. So we're very glad to start with a series of lectures, and we are going to start with the topic that is probably, I would say, most important for translation to clinical practice. And the reason is because the most common reason why a person will have pain on the face will be, number one, dental pain, odontogenic, but the next one will be myogenous. So we're glad to start with this topic. That was not our initial plan, I think, but I think it worked pretty well. And we're going to start today with the topic of myogenous pain. Why is that? Why a person might have pain on the muscles, but most importantly, we want to share with you some strategies that you can use to treat your own patients right away. So that's the topic for today, myogenous pain, conditions that arise from muscles. Let me tell you something first, and I always like to start with that. When you ask the patient that comes to you because he has or she has or they have a complaint of pain, there are some key questions that you want to ask. One is, where is the pain? If the patient uses one finger and point, that's a very good discrimination, and that's usually very nociceptive. And it is usually easy to locate, usually acute, and the treatment is usually very effective. When they use the whole hand and hold the hand in the face, now you're thinking, it's not that exquisite, it's not that specific, so maybe muscle, maybe joint, because the patient is kind of pointing to a bigger area. And then those patients that do like this, that they don't really exactly know where the pain is, those are really a little bit more difficult. And we hope that during this series of lectures, we will have the opportunity to discuss different possibilities with all of you. So let's start just by reminding the group what is important, why it's important to talk about muscles, and most importantly, why it's important to talk about mastication muscles. Well, mastication is a function that is a combination of the nerves and the muscles. So it's a sensory and motor function. It's an activity that happens with a purpose. And in that purpose, many components of the stomatic system are engaged. The memory, the habit, there are many things that are involved for you to be able to produce this act. That is the first part of the nutrition of the system, very important for us. There are two basic groups of masticatory muscles. The first group are the muscles that are related with closure, the grasping muscles, the ones to produce force. And those, the two most important, I would say, are probably masseter and temporalis. There are other muscles that also work a little bit also with side to side, such as the pterygoids, but for now, let's focus on masseter and temporalis. And then we have the other group of muscles that are mostly involved with opening and excursive movements, and those will be all the muscles that are below the border of the mandible that we're not discussing today, and the lateral pterygoid muscles. So why mastication might produce problems? Well, many reasons, because there are many elements. But today we're going to focus on the motor function. So one possibility is that we have a disease or a condition in the masticatory muscles that is avoiding those muscles to function properly. And one example will be, for example, parafunctional activity, could be muscles that have been subject to trauma or traumatic event, or even muscles under an inflammatory state. And we will go over those little by little. But there is also another possibility. I already mentioned that there is a combination of the nervous system and the motor function. So the other possibility is that there is a sensory dysfunction, and we will call that central sensitization. And that is most common when the pain has been with the person for some period of time, but it's very important from a diagnostic and treatment point of view. So we will talk a little bit about that in a moment. So if the muscles of mastications are not working properly, we have many problems. One problem could be that the patient doesn't have force to bite, so no grasping, or it could be that the patient cannot open the mouth fully. And because of that, they do have an issue and a problem. Just remember from your physiology times when we were all health sciences students that the muscles are basically a combination of fibers, and the fibers work in a way that they produce contraction and distraction. So they have that ability to slide. But if we have trauma, that ability is lost, and the patient might have inflammation and some strain on the fibers. In a good scenario, those fibers are also under recovery, and because of that, the patient is in a continuous process of having some limitation of the movement because the environment that is required is an environment of resting. And that will be the first reason why a patient might have pain on a muscle traumatic event. Trauma could be something such as a hit, or also could be micro trauma for a patient who's, for example, doing a lot of clenching and grinding. So there are multiple possibilities for trauma. In some cases, there is not only trauma, but also a contraction or inability of the muscle to relax. In that case, the muscle is in trismus. So it has a continuous sustain of that contraction, and we will call that trismus. This is usually a protection. So I'm guarding myself because I'm protecting my system. So trismus is another reason why a person might have a problem with the mastication muscles. And in that case, we said that the muscle is contracted. Contracture is another topic that we're not discussing today. The third possibility is inflammation that happens also secondary to some procedures, such as, for example, when there is an infection in the area. And in some cases, we see this after a procedure, an intervention, like a dermolar extraction, for example. Could be that there was, that the patient has some type of pericoronitis or something else. So could be inflammation, very rare, but it is possible that that the patient might have some inflammation. And if we have here in the audience people who deals with inflammation in other parts of their body, you are very familiar with the interleukins. We are not going to go over them, but just remember that if the patient has an inflammation, there are different mediators that are there and that we need to deal with them. And we need to try to treat that patient properly in order to reduce that inflammation. And finally, my favorite one is central sensitization, because it's not as well known. And if the patient has central sensitization, means that the pain on the muscle is coming from the brain. It's not from the periphery anymore. And in that case, you can keep treating the periphery. That's not going to help that patient. Because in these cases, what happens is that the nociception, the nerve fibers, are behaving in an erratical way. The phenotype of the fibers change. So no longer a soft touch is only soft touch. Now it's also pain, because there is a transformation of the receptors in the periphery. And now any stimulus that shouldn't produce pain is able to produce pain. We will call that allodynia, that is painful response to a non-painful stimuli, or hyperalgesia, exaggerated painful response. So we have different options, different possibilities, not only one. If there is inflammation, well, we treat the patient with an M.Ed. If there is trauma, we put the patient on ice packs and give it time. If there is trismus, we need a muscle relaxant. But if the patient has central sensitization with a myogenous condition that has to stay with that patient for a longer period of time, in that case, we might need to treat that patient with medications that will target the central nervous system. And a couple of examples are the gabapentinoids and the tricyclic antidepressants. But today we're going to give you a lot of strategies that will help you to identify these situations. So how do we identify if a muscle is in trouble? Well, we evaluate the muscle. That's not up to me, but to Dr. Ahmadieh. How do we analyze and evaluate a muscle?
Thank you, Dr. Padilla. So Dr. Padilla went through all the physiology and basic knowledge we need to know before we go to clinical exam. I want to mainly focus on how we palpate the muscles, what are the muscles of mastication, the cervical muscles that we want to palpate in the practice, and how should we identify the thought bands or trigger points. So I will start. So first, I want to go briefly through the anatomy of the masticatory muscles. And okay, so as Dr. Padilla mentioned, the major muscles that we want to examine and are important for us are temporalis and masseters. For temporalis, we want to palpate the anterior part, middle and posterior sections. And for masseter, we are gonna palpate the deep part of the masseter and superficial masseter. So these two muscles are really important. And if you see like patients suffering from myofascial pain and myalgia, usually the masseter and temporalis are tender. And meanwhile, I'm doing the presentation. Please feel free to add your questions or comments in the chat so we can discuss later. So this one is again medial pterygoid, and contraction of the medial pterygoid can causes jaw closure and also jaw protrusion, as we discussed. Lateral pterygoid is another muscle that, although we are not directly palpating the lateral pterygoid, but we need to know the function of the lateral pterygoid, which is a jaw opener, and there are small superior head and large inferior head for the lateral pterygoid muscle. Bilateral activation of the lateral pterygoid cause protrusion, and unilateral contraction cause like lateral movements. Like you may see like some patients that they come to you, then they complain of like their bite is off, or they get like kind of posterior open bite. Like one of the reasons for that might be spasm of the lateral pterygoid that we are going to discuss when we go further in the lectures tonight. There's another muscle is digastric, anterior belly and posterior belly of the digastric. That's again, it's good to know. It's not like something we palpate every day, but we should know about digastric as well. Especially like some of the spasm, sometimes the spasm of the digastric or any of these muscles, I'm going to discuss later that it may refer to teeth, and it may present as a teeth pain, and we want to identify where the source of the pain is. Regarding the cervical muscles, the first important one is the sternocleidomastoid or SCM. And SCM has a sternal head and clavicular head. The next one is trapezius muscles that we want to palpate. Like the trapezius, it's a very large muscle, and it's very common to have like spasm in the trapezius. And again, the pain can refer to the head and neck, other head and neck areas. There are other smaller muscles in the cervical area, semispinal capitis and splenius capitis. Again, those are like kind of accessory muscles. They are not as major as SCM and trapezius, but again, I just added here that you know that these these muscles exist, and there's levator scapula. So after reviewing briefly about the muscles and knowing about which muscles we want to mainly palpate, which was masseter, temporalis, SCM, trapezius, these were the major ones. So we want to know like what type of techniques should we use to palpate the muscles. So one technique can be a flat palpation. So the mainly used for like temporalis muscle or masseter muscle, we can use the flat palpation using like the pad of our fingers to palpate those muscles. And you can like try different ways, like however you are more comfortable, but the best way is to like using 1 or 2 fingers that you will be able to localize the pain, and like looking for taut bands, because like if you palpate the masseter deep and superficial and you ask the patient if it is painful, and then the next question would be if the pain is referral. And if the patient says yes, you may think of myofascial pain and look for taut bands and trigger points. So it's always nice to like move your fingers and look for those taut bands and to be able to localize them. The other technique would be pincer palpation, that it's like we mainly use for like SCM, and we use for trapezius. For larger muscles, we can do pincer technique, and it's sometimes cause like the local twitch responses. Snapping palpation would be like another type of palpation, and again, it would be like very similar to like how you play the guitar, like you move your hands and fingers and you look for like the certain taut bands and trigger points. So these were like, you can use again, based on like which muscle you are going to palpate, you can use any of these techniques. The major ones that we use are flat palpation and pincer palpations. So now we know that we need to palpate the muscles. The next question would be how much pressure should we apply on the muscles to palpate? Because you may think of like just slight pressure that may not cause pain, or a lot of pressure may cause like pain in anybody, even without myalgia or myofascial pain. So they recommend that to use like a 2 kilogram of pressure on the muscles, and it would be like twice as more of the pressure you use for the joint. For the joint, we are going to discuss in like future lectures, but we are all around, we use around 1 kilogram of pressure, but for the muscles, we use like twice more. And first, you can just palpate it for 2 seconds, and then you look for trigger points and taut bands. When you found the taut bands, then you can like keep it a little bit longer, like for 5 seconds, and ask the patient to see if the pain radiates to anywhere, or does it refer to anywhere. Sometimes the pain, the patient tells you, refers to like my forehead or to the teeth. But again, the next question would be like, does it replicate the patient's chief complaint? Because the muscle might be painful, however, it may not be patient's chief complaint. So that's again, an important factor, that if the pain is referral, or if there is a taut band or trigger point, is it patient's chief complaint or not? So here I put like how an example of how we palpate the muscles. This is a person palpating the temporalis muscle, anterior temporalis, middle temporalis, and posterior temporalis. Again, when you palpate, you ask the patient if the pain is mild, moderate, or severe, if there is any pain. And the next question would be if the pain refer to any location. So this one is again masseter, one of the most common muscles in our field that causing myofascial pain and myalgia are deep masseter and superficial masseter. So again, as you see, this doctor is palpating the deep and superficial masseter with more of a flat technique, and then look for trigger points and taut bands and ask the patient if the pain is referred. The other area is, you see here, we are using the pincer technique. We are like for the SCM, you can palpate the upper and lower head of the SCM. Just for the SCM, since it's in the neck and it's very close to like some critical areas like jugular vein or carotid, we should be careful and like palpate the SCM gently. And then again, similar to other muscles, we can look for taut bands and trigger points. This is the trapezius, one of the most common muscles causing myofascial pain and myalgia. So we want to like palpate the trapezius and ask the patient. The purpose here is not checking the shoulder movement. The purpose is looking for taut bands and trigger points, and if the pain is referral. And at the end, you want to palpate the temporalis tendon. So you go like with your finger, you can go like at the coronoid and like palpate the tendon and ask the patient if it is painful. So if the patient complains of pain at the temporalis tendon, then we can make the diagnosis of tendonitis for temporalis tendon. And you may ask, like, what are the common referral patterns for these muscles? Because like the pain, we said the masseter, especially masseter temporalis, the pain may refer to teeth. And for us as a dentist, it's very important to like detect the myofascial pain as one of the most common causes of non-odontogenic pain. So obviously the most common cause of tooth pain is odontogenic, is pulpal related. But in the cases that it's not related to the teeth, the most common cause can be muscle related or myofascial pain. So this is like a referral pattern. Like these are the most common referral patterns, but it's not like 100% rule. The pain may refer to other areas too. And here also for the neck muscles, for the SCM and trapezius, and we look like it shows where the referral pain goes. For masseter, again, I emphasize on masseter and temporalis, since those are the most common ones, like getting painful in patients with bruxism or myofascial pain. So they may, for masseter, usually they may refer to the posterior teeth. For temporalis, also anterior and posterior, especially like anterior temporalis may refer to anterior teeth. So it's very important to like think about these possibilities when your patient complain of tooth pain. So the next slide I wanted to emphasize, as Dr. Padilla mentioned as the first sentence in her lecture, that's like, do you know the myofascial pain or myogenous pain is the most common cause for non-odontogenic pain, tooth pain? So like knowing that, so if you had a patient that complain of any type of tooth pain, which you couldn't find any cavity or pulpal issues or periapical lesion, always think of ruling out myofascial pain. So think of it might be just a muscle-related myalgia or myofascial pain. How can we confirm the diagnosis of myofascial pain or myofascial pain syndrome? So one of the criteria, as we discussed, we should be a referral pain. So the difference between myofascial pain and myalgia is that in myofascial pain, there is a referral pattern, whereas in the localized myalgia, the muscle is just painful at the site of palpation and it's not a referral. Whereas in myofascial pain, there is a referral pain, and if you like palpate the muscle, usually you can look for like taut bands and trigger points. In like many cases of myofascial pain with the trigger point, they may respond with just home-based physical therapy that Dr. Davoudi is going to explain to you. But in case of you do the trigger point injection and the pain goes away, again, that would be another diagnostic test to confirm the myofascial pain. Here again, I reviewed the myalgia versus myofascial pain. Myalgia is more localized. The pain is usually mild to moderate. There is no trigger point or referral pattern, whereas in myofascial pain, it's referral pain. It's usually more severe, like moderate to severe pain. And there is a trigger point or taut band. And as I said, in case of trigger point injection, you will see the pain will be reduced significantly. So at the end, I just wanted to, I just put a case report. I thought it might be interesting to you because you may see like similar patients in your practice. So this patient is a 41-year-old female. She refers to the orofacial pain clinic. 6 months ago, she had a complaint of tooth pain, like in the right maxillary first molar. And the dentist, according to patient's report, the dentist couldn't find any cavity or decay or any lesion with the tooth. However, the dentist thought it's probably the pain is coming from the tooth. and did root canal and RCT, which didn't remove the pain, obviously, because the source of the pain was not related to the tooth. And then the next step, the dentist extracted the tooth. Again, the pain still was there. And the pain this time was more localized to the second premolar. And dentist started doing RCT on second premolar. And then after that, still pain was there, doing extraction. And patient comes back with the pain in first premolar. So this time, the dentist and the patient came to the conclusion that it's probably not coming from the tooth, and the dentist referred the patient to the OFP clinic for further evaluation. In the evaluation, there was no asymmetry in the face, no pain or clicking in the joint. There was just mild tenderness in the TMJ, arthralgia, and then the active and passive opening when were within the normal range. Muscle palpation showed 2 trigger points at the temporalis and masseter area on the right side. So you see, as we discussed, the temporalis and masseter may refer to the posterior teeth. So in this patient, there were 2 obvious thought bands, trigger points, that the pain was referral to the molar and premolar region. So diagnosis for this patient, since there were obvious thought bands and the referral pattern, the orofacial pain doctor thought of more of myofascial pain syndrome, but also they couldn't rule out the neuropathic pain, or since the sensation of the pain was a little bit like burning and tingling, they couldn't rule out the neuropathic pain, but they put it in the lower part of their list, and the myofascial pain was on the top. So what they did for treatment, they started home-based physical therapy, stretching, asking the patient to stop poor function habits, going on a soft diet, and doing the N-stretch exercise. That's one of the common exercises we ask the patient to do, to stretch the masseter, and then the pain was significantly reduced. And so this was just an example. I wanted to mention that even you see in this case, they even didn't do the trigger point injection. But in case of you need to, you can go further step and do the trigger point injection, but never in a case that you don't find any obvious lesion or don't from the tooth. So never do RCT first, think of neuropathic pain, myofascial pain, especially myofascial pain, which is the most common cause of non-odontogenic pain. Thank you so much. So please let me know if there was any questions.
Thank you, Dr. Ahmadieh. There are some questions on the chat. We're answering them as we move forward, but we're going to have a question and answer session at the end. So you did mention different conditions, and one possibility is that when you do your palpation, as you explained, the patient has localized pain. We will call that localized myalgia. Right. Could be secondary to trauma, could be an inflammatory process, but you also mentioned the possibility of referral pattern or referred pain. In that case, we will call that a trigger point, and Dr. Ahmadieh has covered some of the most common patterns. Now, when you do a palpation on those cases and you find a trigger point, one of the things that you could consider is to perform a trigger point injection. And Dr. Davoudi will now cover the topic of the use of trigger points in masticatory muscles. So let's share your screen, Dr. Davoudi, your turn. Azadeh, I think you have to stop sharing. Yeah.
Sorry. Yes.
Perfect. Now I'm going to share my screen. So you can. Okay, so you guys can see my screen. Okay, wonderful. Okay, so as we mentioned, I have no financial interest. So as you can see on this the page, I just want to show you there are lots of nerves, vessels, and we have a parotid gland. So whenever we are doing any trigger point injections, we have to know our anatomy. before knowing, we shouldn't do any treatment. Okay, so then I'm going to show again the muscle of the masseter and temporalis that most of the time we are doing the trigger point injection as our facial pain. That's the most muscle we do the trigger point injections. So I just put these two pictures next to each other so you can see the proximity of muscle and other organs that you can see. And we have to make sure how much the needle it should go inside, where are the anatomy, where we should inject, and we have to be careful. So on this diagram, as you can see, I put the stuff that we need for the trigger point injection. So we need lidocaine. I'm going to show a live so you guys can see. Most of the time we are using the 1%. So we need a needle and then we need a pad and alcohol wipe to clean it. And also we need a cold spray. Why we're using the cold spray, it's kind of give them some anesthetic feeling. So when we are doing the injection, patient, they don't feel that pinch under their face. So it's less painful, let's put it this way. And on the lower picture, as you can see, it shows the taut band on the muscle and how we should hold the muscle. Of course, there are different ways to hold. Some patients, they like the pinching holding, or some people, they like the strip. But it depends how we train and how we are comfortable. So before I go to the trigger point injection, as Dr. Padilla and Dr. Ahmadieh mentioned, we don't start with the trigger point injection. We have to do different treatment, home rehabilitation, stretches, heat pack, maybe medication. And if it didn't work and there are still trigger points, then we do the injections. And for injection, as you can see, my screen, and this is the lidocaine. Most of the time, we are using the 1% without the epi. There is no epi on that. And the needle. So I'm using the 27. It's a long needle, but if we want to withdraw, we don't have to use this one. We can use the 25 to withdraw the medication. Okay, so this is our 1% lidocaine and withdraw. So I have the gauze. After I inject, I use to clean if there is any blood coming out. And I have the alcohol pad. It's better to have a few because first we clean the area to make sure there is no, especially for a woman, if they have a makeup or if there is anything, so clean to make sure there is no bacteria for the infection. And always, before I inject, again, I remind my patients if they have any trigger point and where is the location. So as you can see on a masseter, so these are the masseter, the trigger point, especially on the teeth, and we have the temporalis. Where is the trigger point it can trigger. So we ask the patient, when we palpate, are there any referral pain? Are there any? So then they can locate that. So for this, I withdraw. We use 0.5 for each trigger point. So when we withdraw, I make sure there is no bubble. The liquid is all the way there, so I can check. And when I want to do injections, this is my mannequin, so I can show it to you. Hopefully you can see very good. So the way we palpate with 1 finger or 2 fingers, but preferably because we want to find the taut band, so I palpate the muscle. And I ask the patient, do you have a pain? If they have a pain, I hold the place. And I ask them again, is this the pain that radiates? If they say yes, and you can see under your finger, there is this taut band. You can feel it. And the patient can tell you, okay, yes, this is the place. So when I have the place, Then I get the marker. Most of the time we are using the marker that it's you can place on the face. They can clean it. You can mark there. Or sometimes I use the injections, the cap, to put it shows where I should inject. Okay. And then I clean with the wipe very carefully. And I want to make sure I don't have any makeup on my patient. Okay. So the way I'm doing the injection, I prefer to hold the muscle, especially on a masseter, because I can feel the muscle where I should inject. But some, they like the stretching. So either way, you have to locate and you know where you're injecting. And then I'm gonna go, I have the fulcrum of my finger, and then I go inside perpendicular, and I go with this one, it's very hard. But I go until I pass this much. I hope you can see my needle. And then I aspirate. I want to make sure there is no blood. And then I do injection. When I do injection, I hold there. And then I do, we call this salt and pepper. We go in and out, open up that thought band. And sometimes you can feel you are breaking those thought bands. And then again, if I want to add more, again, aspirate, because I changed my needle position. I aspirate, make sure there is no blood, and inject the rest. And while I'm injecting, I'm coming out. And I have always be ready. I have my gauze, hold it there. Just gently, and especially if it's a masseter and we want the patient to get this stretch feeling, I ask them to open their mouth, put their tongue behind their upper teeth, and stretch. We call this an stretch. I'm going to show on the later, but that's how we make sure patient does the stretches. So then I use the cold pack and place on the face and ask the patient to hold it for 10 minutes. And for that day, on and off, they have to use their cold pack, and make sure the patient is following up and they do the stretching and cold pack the rest of the day. And from the next day, then you can do the heat pack. But later on, I'm going to go over the home therapy after we finish with the rest of the presentation.
Thank you, Dr. Davoudi. So that means that if you locate a trigger point, you start treating those patients with a home-based protocol that we will discuss in a moment. But also there is the chance for you to try to interrupt that thought band, producing a local injury to try to bring good chemicals to the area. So you're moving from a chronic condition to a more acute condition, hoping that the patient will get better. Yes. And that's the purpose of the trigger point, right?
Yeah, yes. And also if the muscle are in a contract most of the time, and the nerve, and especially, I forgot to mention the lidocaine, why you're using the lidocaine, because it gives the patient some numbing sensation. Then they have less pain. Then patient has the ability to do the end stretch more and easier for them to do it. Because if they have a pain, there is no way you can ask them to do the end stretch or any exercises. So that it's kind of helping them.
Mm-hmm. Thank you very much. Now, something interesting when we discuss about the masticatory muscles, we mentioned masseter muscles and we mentioned medial pterygoids, but we also mentioned the temporalis. And we showed you some maps or some common referral patterns. So it's not rare to have an intersection with muscle, myogenous, pure condition, and what we call tension type headache. Is not rare. It's not rare that the patient will complain, not only my face hurts, also I develop this headache that is not going away. And sometimes that intersection makes our diagnostic process a little bit more complex. Because of that, we decided to discuss today with you a little bit about tension type headache as well. Tension hype, and for the condition, we want to go over basic stuff. We want to go over the general characteristics, some of the possible potential diagnostic tests that in this case, very interesting, will be muscle palpation. And obviously, we want to talk a little bit about the treatment and that intersection between myalgia, trismus, myofascial pain, and tension type headache. We are also going to provide you some additional resources that you can use with your patients. It is not uncommon to call the tension type headache the stress headache. So people say, yeah, when I got very stressed, I get this headache. So is it related with muscle contraction or something else is going on? What's happening? There is a classification with a specific criteria about the headache, and tension type headache is part of that criteria. So basically says that you can have frequent headache, infrequent headache, continuous headache. You could have cranial tenderness at palpation. You might not have that. So there is different characteristics. I'm going to keep it simple today. And we're going to say that the tension type headache will be characterized by having recurrent headaches that usually don't last too long. Usually could be, 1 hour, 2 hours. Some patients, though, might have the headache for a very long period of time because they have central sensitization. Is my favorite concept today, huh? But what is important here is that the next question after you ask the patient, where is the pain, and they point, your next question will be, can you describe the pain for me? Muscle pain is usually dull and achy. Very rarely will be sharp or throbbing. So it is usually dull, achy, and is usually of moderate intensity. It's usually not very, very severe. Most of the time, the patients will say that they feel a band around their heads. It's usually bilateral, does not get worse with physical activity, and the patient will usually do not have some of the migraine features such as nausea, vomiting, phonophobia, or photophobia, even though they might be present. But most of the time, they are not present with these cases. The criteria has been published by the Headache Society. So there is a specific criteria to say that a patient has tension type headaches. And sometimes we only say, oh, if the pain is bilateral, dull, achy, moderate intensity, that's tension. But, there's some criteria. And one is that the sensation is like tightening. The patient feels like a pressure, like a band around the face. And remember that the patient might have 1 or 2 features of migraine, but that is not common at all. This is an example of a drawing of a patient who points to the area, and look at the drawing. It's not only on the frontal area, but goes down also. And in some cases, go back to the suboccipital area. And Dr. Ahmadieh already covered some of the muscles that are there as well. So the intersection is all over. There is a complete relationship with all those structures, probably related with the mechanism at the level of the central nervous system that is producing all these headaches. Some of the features, this is a condition that is most common in young patients. So usually between 20 or 30 years of age, goes up when you are very busy. So 30 to 50 is not that common when you are older. On those patients, we have things that are different. And even though teenagers might have it, it's not that common. I know that we have at least one person who does ortho in the audience, because you already talked about that. And that's not uncommon in teenagers. You might have a patient with tension type headache that is related with a myogenous disorders. The headaches can be precipitated though by stress, fatigue, menstruation. So all of that is possible. And this diagram is the one that I like, because the pathogenesis is multifactorial. So muscles might be involved, but look at this. Look at this diagram. We might have a participation of the central nervous system, the brain stem, the limbic system, all the control related with the sleep, with the stress, hormone related. So all of that has an interaction. So it is possible to have a hyperactivity at the level of the central nervous system that produces not only the headache, but pericranial tenderness. And we will call that pericranial myofascial pain. You see how everything is related? So it is possible that this myofascial condition that is mediated by a central sensitization of the central nervous system is producing at the same time the headache complaint. The area on the brainstem that might be involved is basically the trigeminal nucleus, or and very, very specifically, the lower part of the trigeminal nucleus, that is the subnucleus caudalis. And in that area, we also have an input from the cervical area, C2 to C3. Well, some people say it's even below, up to C4 probably. Why is that important? Because now you have a patient who might have pain on the masticatory muscle, masseter, pain on the masticatory muscle, temporalis, pericranial tenderness and headaches, and also cervicalgia. So it is interesting to have that relationship of all these different conditions that are happening together from a mechanism point of view. So what we have is that usually some of the fibers are related with sensation, not with pain. For example, pressure. But if those fibers get a lot of stimulus, because there is a lot of nociception happening and the pain continues and is not solved, those fibers start thinking, come on. So, I should behave as a painful fiber because seems like that is what is needed. So they switch. There is a phenotypical switch. And now what we have is fibers such as the A alpha and A beta that are basically mechanoreceptors start behaving as nociceptors. So now we have a new group of fibers that respond with pain to non-painful stimulus. And we mentioned that already. So it is possible that if there is a local injury or an inflammation that is persistent, the patient might start getting this chronification of pain. And now we need to be a little bit more aggressive in our management because we don't want these fibers to keep converting. We want them to go back to the initial vocation that was just to respond to, for example, pressure. And I'm putting here the same diagram that Dr. Azadeh shared with us. That is a little bit of those patterns where the X's represent where you do the palpation and the red represents the areas of referral. So look at this, temporomandibular joint, supraciliar area, upper teeth, all being stimulated by palpation of the temporalis muscle. So these cases, they do not have dental condition. So they shouldn't be receiving dental treatment unless there is a need for that. These cases should be receiving treatment for myofascial pain. One example would be a trigger point injection, but another example would be to try to reconvert the A delta and A alpha fibers into their own proper vocation to only be mechanoreceptors, for example, and not behave as C. So that's kind of the idea of central sensitization and a little bit about the interaction between the two areas. This is another one, and I'm just going to put some studies here. This is from a very popular textbook that is Okeson's book. This comes from chapter 17. And basically what they say is that what he did is he did some electromyographical studies with patients with tension type headache or myofascial pain to see what was the behavior of the muscles. And definitely in the presence of stress, the muscle activity goes up. And it's kind of obvious, right? Because you kind of contract all over. So that contraction, if happens many, many times, guess what? You are stimulating mechanoreceptors and they start thinking, I should be a nociceptor, right? Like Halloween, they dress, they use a costume. So that's what is happening. And we have to be very careful with that. Also remember that the tension type headache could be present on the cervical region, and that it will be even possible to refer pain to the front of the face. Now, sleep is also related with headaches, and because there are some conditions that are related with the sleep pattern. If the patient is clenching and grinding a lot, is putting a lot of sensation or activity on the masseter and temporalis muscles. So it is again possible that a lack of proper sleep architecture will produce or will be a risk factor for the patients to have different headache conditions. And one of those conditions is tension type headache. There are others that we're not discussing today, such as hypnic headache, just to mention one, and other conditions mostly related with the level of oxygen. But on this case, we're talking more about that continuous contraction on the masseter or temporalis muscle and how that might be part of this of regulation or changes at the level of the central nervous system. Again, one of my diagrams, I always like to have them because I think it's the only way to kind of understand what is going on here. And this one over here has some involvement of different neurotransmitters in the trigeminal vascular system. Everything happening at the level of the central nervous system, and how we can have some participation with the arousal, the sleep-wake control, and of course the biological rhythmicity that happens when you sleep and wake up at certain moments of time. And what this diagram show over here is the relationship of the trigeminal nerve. On this case, the diagram includes trigeminal nerve ophthalmic branch, the cranial autonomic structures, and here we talk about the autonomic system, and also the input from the cervical area. So now you have a patient who could have not only pain as response to the palpation, but also an autonomic response. So it's possible that the patient, when you press, has sudden flushing on the skin, or sudden contraction of the pupil, or even some lacrimation in one eye. It's not because you're palpating too hard. It's basically a response that is more from the autonomic system, and that is perfectly possible. I'm going to skip this because I didn't want to talk about that. I want to be sure that I mentioned the diagnosis of this headache could also be the exclusion of other problems, other conditions. And we had a question before on the chat that I don't know if everybody read about it, and is what happens when the patient has, for example, an imbalance of electrolytes. So the patient doesn't have a good behavior of the calcium channel blockers. Remember that always we can have primary headaches and secondary headaches. And your responsibility as a provider is to be sure that you don't miss those, that you know what's going on. And one way to do it is to use a headache inventory with a pain diary, when you keep track of what's going on the patient, and the patient can tell you what has been going on during the last weeks or so. So how we manage these patients depends on what we're talking about. So I'm going to stop my share for a moment because I want to be sure that you don't get distracted trying to read the slide. If the pain is in the periphery, we put in place peripheral therapies. And a common analgesic might do the trick. If the pain is related with inflammation, we need an NSAID on board. The topical NSAIDs, they don't work as well for muscle pain. They work better for joint pain, but they might work, especially if the patient has gastric issues. That might be an issue. That might work. For peripheral pain, you can also put in place a home-based therapy. We will dedicate around 10 minutes to that topic, so I'm not going to cover that right now. If the patient has trismus and there is a clear contraction with limitation of opening, you might add to that case a muscle relaxant. A muscle relaxant for a short period of time, because your purpose is to start moving that muscle, and then the patient can start functioning better. So no more than 2 weeks. Most of the cases, we prescribe a muscle relaxant for a week. And we like to prescribe it at night just because it's easier to sleep. However, if the pain is already centralized, those peripheral approaches are not going to work. On those cases, we have to jump to medications that will work on the central nervous system. Now that I hope that I catch you, let me go back to my slide. What can I use on these cases? Is a simple analgesic enough? Is paracetamol enough? Is this enough, or do I need to use something else? So on these cases, we want to use something else. So one possibility is to use medications such as tricyclic antidepressants or even gabapentinoids. And I started today, one of the first slides I used today was that. Why we use that? We like to use a tricyclic antidepressant because it does act at the level of the central nervous system, promoting modulation, promoting inhibition. So it does help from the upper to the lower part, comes from the central nervous system to the periphery. If we decide that we don't want to use an TCA, for example, a tricyclic antidepressant, we can use an SSNRI. And a good example is duloxetine or Cymbalta. It does work well for centralization of the pain as well, and it has been approved for conditions such as fibromyalgia. So it does work well with myofascial pain. And finally, in some cases, you want to work on that nerve conduction, on the receptors, and because of that, you want some type of medication that block the electrical activity of the nerve. And in that case, our favorite one might be a gabapentinoid. So we can use things such as gabapentin or Lyrica. However, there is also the possibility to promote healing through non-pharmacological alternatives. And even though we're going to talk about our specific protocol, I wanted to take the opportunity to talk about the well-being of the patient. So you want to be sure that the patient takes time for themselves, that they manage their stress, their anxiety, that they are sleeping well. All of that helps because all of that will increase the chances of the patient to feel better. So some examples here. We can do some posture correction exercises. So we want to try that the muscles are not tight, are not tender. I like to tell my patients, for example, the last hour before you go to bed, you can relax a little bit. Do something fun. Relax those muscles. Don't go bed like this. So relaxation, posture. Work on your back. Be sure that the muscles are relaxed. There are other alternatives. Acupuncture has shown to be effective. Jouliana already showed us a little bit of the salt and pepper, the dry needling. So that means acupuncture might work. Not beyond the whole philosophy of acupuncture. Also, it might help because it produces this salt and pepper activity, this dry needling, and that is very useful and that helps because, again, you're bringing very good potential chemicals into the area. And I couldn't not mention the possibility, and I know some of you are eager to hear a little bit more about Botox. And yes, Botox is a possibility for resistant myofascial pain. The only caveat is that you have to reapply it because it wears off. So it's not something that it will be there forever, but it will help in some cases to reduce that sustained contraction that the patients might have. So it is possible to use it. And there are several studies, and here I'm showing a couple that does work with that. So I want to be sure that I give Jouliana time to go over some of the home-based therapy before I do my closure. So I'm going to stop here for a moment and I'm going to give Julie time to go over what is the peripheral idea of home-based therapy and why that therapy might also affect the behavior at the level of the central nervous system. Dr. Davoudi.
So again, I'm going to share my screen. Okay, so next slide, so when the patient comes and we do all our comprehensive examination, we measure their opening, we measure the lateral movement, the muscle are tender or not, the joints are tender or not, we come up with our diagnosis. And after we have a diagnosis, based on our findings, we do the treatment. The treatment, we kind of explain to patients what are the findings and what is our plan and what is going to be our future plan. So give them kind of hope we have planned for that. It's not just one time they're coming, we're gonna see them next time, then that's it. No, they have to know we have a plan for them. And every patient, they are different. It can be a few months, it can be a year, it can be annual follow-up with the patients based on their needs. So let's see, the patients comes with the myofascial pain, they have some muscle pain, they have a tenderness, they have some trigger point injections, and they have a trigger point, and also they might have some joint pain. Today, we are not talking about the joint pain. However, I add exercises which I find even the patient, they don't have the joint kind of pain, but it might have underlying covering with the muscle pain. So this very simple exercise, they can use it. So our plan is start, as I mentioned, explain, and then we go one by one. We explain to the patients, okay, so for a month or two, you have to stop eating some hard, crunchy, chewy food. It can be beef, it can be chips, it can be any kind of nuts or fruits that it's very hard to chew. So we ask them if they can reduce it. I know for younger kids, we see it's hard, but at least we ask them, okay, you can have it, but reduce the amount. They don't have to stop it because no one likes that, right? So we want to have something, but very small amount. So we address the diet. We ask them, eat something soft. We don't ask them to go to soup or something liquidish. No, we want them to have to use their muscle because the muscle should work. Otherwise, they are calling use it or lose it. So they have to use their muscle, but not to the extent they exaggerate their pain. The pain is like it's too much, they cannot eat. So they have to go softer diet. And then we ask them, everything starts with their posture. So for our posture of the facial muscle pain, we ask them, they have to use N position. What does that mean? Even you can practice with me. When you're saying word N, your tongue, it's end up behind your upper teeth. And then you close your lips without touching your teeth. So that's the relaxed position, which muscles are relaxed, joints are relaxed, teeth are not touching. Because the moment we are touching the teeth, we are sending the signal, the pain signal. So we don't want that. We want to avoid that. And during the day, you have to let the patients know they shouldn't touch their teeth at all unless they are chewing or they are swallowing. That's the moment the teeth should touch. And don't try to find the contact for them. There is no contact whatsoever during the day. The teeth, they should be space between them. So when they learn the position of the tongue, the position of the muscle, it's gonna take a while because we are not trained to do that. So for patient, it's gonna take a while until they get used to it. When they get used to it, so that's gonna reduce their clenching habit during the day, patient has. And also during the night, because the tongue is in the correct position, imagine they have enough space, even if they have a sleep apnea, it shows it helps them to sleep better. And it reduces the paroxysm. I'm not saying they're gonna stop paroxysm or clenching, but at least the muscle they can learn. So that's we start with the end position during the day and practice. They have to hold it every day. So it's most of the time they're asking us, okay, how long I should hold it? I'm like every time. If you're not talking, if you're not chewing, you should separate your teeth. Then we go to the next. If the patient tells you, when I open my mouth, I have lots of pain, we have to let them know the maximum they should open, it should be 3 fingers, like this. 3 fingers, check. They shouldn't go more than that. And it go less than 2 fingers. Why? Because if they don't use the muscle, again, all the spasm, all the contraction is gonna happen. Then they're gonna start having limited opening. So we don't want that. So something between 2 to 3 fingers. That's the opening they should have, and avoid wide opening, especially if the patient has hypermobility they have to stop that. Otherwise, they're gonna cause lots of open locking for that. And if they open too much again, they're gonna cause lots of damage to the disc and the joint, okay? So that's the next thing we should inform the patient. Next one is the parafunctional habit. The first question that you're asking the patient during the interview or the examination, you're asking, okay, are you grinding? Are you clenching? Are you doing cheek biting, lip biting, fingernail like biting, or ice cube? Like I heard lots of, especially the younger kids, they are using the eyes. So those are the parafunctional habit, because constantly they are putting their muscle and a joint in a function that it's not good for them. They are overusing their muscle and joint. So we have to let them know avoidance of the parafunctional habit. And it was last week, I had a very young kid, 7 years old. So the patient was having this movement of the lateral movement. That's the parafunctional habit, because they are saying, okay, when I'm doing this movement, I feel better. But you have to let them know, no, that's causing more issue for the joint. So they're gonna develop more and more pain, and they are not gonna let the muscle and the joint to be relaxed. So we have to let them know any movement rather than open, closed in a straight line, that's a parafunctional habit. So we have to address that. And next, I'm going to go over the home-based therapy. So as I mentioned, there is this hinge exercise. That's for the joint. If the joint has early clicking or they are dry, if they have an inflammation, if you're touching the joint area in front of the ear and they said, oh, I have a pain, that's their joint pain and it's inflamed. So this exercise is more of that for the joint. And most of the time, we're asking the patient if they have a muscle pain, especially, it's better to use a heat pack. The heat pack, it can be moist heat pack or the just regular heat pack or a towel. And the next one is the end stretch, which I'm going to demonstrate how to do it. And the passive stretch, this exercise is for patients, they have limited opening. And I'm going to show you how to do it. But with this exercise, we need the cold pack, or we have to use the spray, the cold spray. So while we are doing the hinge exercise, as I mentioned, there are several benefits to that. It can be increase the joint mobility, improve joint lubrication, and promotes joint healing. So sometimes, especially with the osteoarthritis or dry joint, they get this pain and inflammation. So with this, we try to promote and do the lubrication of the joint. So that's the hinge exercise job. So during the day, we ask the patient open and close their mouth. As you can see, I hope you can see my video. It's like you're chewing without touching your teeth. Okay, or it's a teeth shivering, and they should do. I like it to do 15 seconds every 2 hours, but also they can do 6 seconds, 6 repetitions, 6 times a day. But it's easy for the patients to accept my 15 seconds every 2 hours and easy to do. I ask them, you can do anywhere, anytime. It doesn't matter what you're doing, you can do these exercises. So again, it's open, close, very quickly without touching your teeth. So again, if you want to see my video, it's very simple. Just the lower jaw, its movement, very quick. And you see the teeth are not touching. So that's for the hinge exercise. The next one, as I mentioned, is the heat pack or cold pack. And for the muscle, we prefer the cold heat pack, and especially the muscle, they like the heat and the comfort. They don't have to buy any of those that I put here. They can use the towel that they have. They can put in the microwave, or they can put in a hot water, the moist heat pack. It's very comfy. It's very easy to use. And especially I ask my patients to use the moist heat pack before they go to bed, because that's kind of relaxation. It's easy to use and they enjoy. So they use the moist heat pack. But if they want to purchase one of those, they are not that expensive. They can go, they Google it, they can go Amazon, or they can go anywhere. They can find this ice or cold or hot pack. So for the heat pack, I ask them to cover their face, or if it's a neck, it doesn't matter. They can cover their neck, and everywhere that they have a pain, they have to hold it for 10 to 15 minutes. Some patients, they like to hold it more. That's better. There is no harm to them, but not less than 5 minutes because they don't see any effectiveness. So they should go 10 to 15 minutes to hold there. And every time they make sure the heat is constant, staying the same. It shouldn't just very hot and then suddenly after 5 minutes it gets cold. No, that's not a good thing. So it should hold, okay? And after that, we are going to the end stretch. As on the picture, you can see the tongue is from the end position that I mentioned, open and stretch. Why we are using our tongue? Because some patients, they have the clicking. So we want to avoid that clicking. And we want to make sure, okay, how much they should open and not more than that. So they are holding the end stretch for 6 seconds, 6 repetitions, 6 times a day. Again, I know for some patients that it's too much, especially if they are working and they cannot use the heat pack and do this stretch. I tell them, you know what, when you wake up, you're getting ready to go to the work or school, just heat pack 5 minutes, 10 minutes, and then do end stretch. During the day, you have a lunch time or you have a break. Another, if you don't have a heat pack, that's fine, just do the end stretch. When you're coming back and before going to bed, that's 4 times a day, and it's good, so they can do it, right? It's doable. So you have to convince your patients and give them a time, exactly, okay, do it this time, this time, this time. Not tell them, okay, go 6 times a day. They don't know how to do it and they get confused. So give them a timeline, okay, early morning, midday, coming back from work or school and going back to bed. So those are the time they should do it. Okay, when we are using the spray or, so imagine patient has hot band, we told them, or they want to do passive stretch for the limited of opening. So we are using the cold pack, and it doesn't matter what cold pack they should use. I'm using this one on the top left side, as you can see. They cannot buy over the counter. That's for the physician, they should order it. And the other one that you can see is the blue color. It's the cold pack they can get from the over the counter. But honestly, they don't need it. It's just for us to demonstrate how to do it. And if and also it can be for the diagnosis to see if the cold pack, it helps them to do the stretches. So I want to demonstrate how to do the cold pack or the spray. So again, I'm gonna show my mannequin, and this is my spray. So this is the muscle that we wanted, the masseter muscle we want to do the spray, okay? So I just go parallel to the muscle and I spray up, down, up, down. And also because I want to do stretch, I prefer to use masseter and also the temporalis muscle. Again, I'm holding the patient eye, holding the ear, I cover with a towel or something, and then I spray. When I spray, I wait a few seconds until they feel that numbness or less pain. Then I go, as you can see on this picture, the fingers, the pointy, my finger on lower teeth, and the thumb on our upper teeth, and we stretch. And we hold for 6 seconds. And we do 3 times. If you want to do at the office, we do 3 times to 4 times. That's kind of for us, for the diagnosis, to see how much, if the patient has limitation, how much we can open. If it's the muscle related or it's the joint related. If it's the soft ending and I feel, okay, I can push it more, that's the soft ending. So I know it's more of a muscle pain. So then I let my patients know, you know what? If you want to do this practice at home, you can use the cold pack. You can buy from the Amazon or anywhere, or you can use the ice, put on the bag, plastic bag, cover with the towel and put on your face. Just rub for a few seconds or 1 minute until you feel that coldness, and then you can do the stretch. I want them to feel that stretch on their muscle. So again, they can hold it for 6 seconds, a few times, and during the day, they can do it maybe 2-3 times. I don't want them to do more because they're gonna damage their muscles. So sometimes they don't know how to do it. So that's how we do the stretches, the passive stretches. But for some patients, if they don't know how much they should push, we ask them to get the tongue blade, tack up the tongue blade together and measure for 40 millimeters. That's the opening they should have. And then every time they can add until they get to that 40. But that's for later if you want to do, if the patient has very limited opening. But these exercises for them, it's easy to do. They don't need anything to buy it. It's just their fingers and a cold pack. It can be ice from the home, so they can use that. Dr. Padilla, I want to go over the night guard. I'm sure they're gonna have a question for that very quick, because that's a separate concept we want to cover. But I want to show them if the patient, they said, okay, you have a bruxer, you are clenching at night, they wake up with the pain in the morning, they get the headaches. So we can ask them, okay, the night guard is another treatment they can have. So as you can see, on my picture and also on the live, the night guard that we prefer, it should be solid, very hard material, and all the posterior is so flat. We are not adding anything, and posterior teeth always they have to touch on both sides. Okay, and if you're wondering what is the white stuff, that's the nylon. And if the patients are very heavy grinder like crazy, they are breaking their night guards over and over, this is another alternative. They are very thin, but they are very strong. So they can use these oral appliances if they want it. But how they are doing it, it's not for all the patients. They have to use the night guard. We have to consider what they need and what is their chief complaint. And this is something later on after we address but they are following their home therapy. They are complying with that. And then we can consider night guard for specific patients. Okay, so that's my part.
Thank you, Dr. Jouliana. So what happened if even doing all the things that we have shown today, the patient is still in pain? What happened with those that they don't get better, the persistent pain? What do we do with them? And you know, it's not easy. Myofascial pain especially is often together with other comorbidities. Patient might have chronic fatigue, might have fibromyalgia, might have depression, might have insomnia. So we need to be sure that all the different areas are being treated. It is not possible to just grab a little piece and let all the others to keep working. So we need to be sure that we cover all the areas from the patient, that we understand the patient. And that is why we need to be part of interdisciplinary teams. We need to work together. I love how this organization brings together physicians and dentists. We have to work together with the physical therapists, with the occupational therapists, with the psychologists. We need to have what is called multimodal therapy. We need to educate our patients. They need to understand what is happening, because if not, they will keep going from provider to provider because they will not get the relief that they are expecting. We might use home-based therapy. We might use pharmacological intervention. We might do trigger point injection. We might do posture training. but also we need to do and convince and motivate our patients to do some lifestyle changes that many, many times are needed. And there are resources that we should be always providing to our patients and take opportunity every visit to educate them and educate ourselves. That's the concept of modulation. That's the concept of biofeedback. That's basically the concept, to understand your body and react properly. There is a simple exercise that I learned once. I saw one person teaching, one expert teaching about management of stress by managing your respiration when you are in a task. And the task was, okay, let's start breathing. And now let's start counting from 100 to 0, but you will subtract 7 each time. So I said, easy peasy, 93. And that was it for me. So I did 100, 93, and then I got, oh, so I have to use fingers or something to count. And the trick was, can you, under stress, keep your breathing gentle and slow? And I couldn't. I'm pretty sure that for us, it's not easy to do. But this concept of biofeedback, that is what it is, to recognize the different signs and symptoms, the different activities that your body has, and manage them. And that's basically what we wanted to share with you. There is a lot of different things that we can do for our patients, but in many cases, we have to do all of them, trying to understand what is going on and helping our patients as a whole. And always, 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 we'd like to provide resources for them. So here you have three links that are there available. I'm pretty sure it's not easy to click on them at this moment, but there are links, there are educational materials. We have a web page that is called Ostro Online, and in Ostro Online, there are some resources. We have been writing blogs there, so there are resources there for you, and please feel free to look into those resources. By the way, I promised that I was going to give the keyword at 8:30, and it's 8:29, so let me give you the keyword for the CE course. It's Ostro space online. That is the password that you need in order to claim your CME. But you also have to complete a quiz that is available on the webpage. So that was the material that we wanted to share, but we also want to hear from you. We wanted to leave some time available for additional questions from the public, from the audience. I know you have been asking questions and we have been trying to answer them as we move along, but please feel free to bring any questions into the questions and answers section on the chat. And if you are in Facebook, feel free to post your questions and we will be looking into them. Okay, Jouliana, this is a question from you related with trigger points. Is it okay to use mepivacaine or any other anesthetic for trigger points if lidocaine is not available?
There are study shows mepivacaine, it's similar to lidocaine, but we prefer lidocaine because it's less toxic, let's say, and we are using 1%. So that's, we prefer lidocaine, but if it's not available, yes, they can use it, but preferably lidocaine.
By the way, it has been very scarce. It has been difficult to get lidocaine, both 1 and 2%, but it is already available. There is an inventory. We were able to get 1 dose vial. And that is interesting. Instead of a multi-dose vial, a 1-dose vial. That is, easier to handle for infection control. So that will be a choice as well. Azadeh, maybe this one is for you. I'm going to go over some of the questions that we already answered because they were not public for everybody. We often see patients who have myofascial pain after orthodontic treatment. What are the treatment options for these patients?
So as we discussed, we can go with starting with patient's education, home-based physical therapy, trigger point injection if we find any trigger point during our exam. And then at the end, if none of these work, we can go, as Dr. Padilla said, with pharmacotherapy. We can go with, we talked about Cymbalta, that's a good choice, Lyrica, if depending on patient's case, if it is very chronic pain, doesn't respond to conservative treatments, then we can try pharmacotherapy.
Azadeh, I'm going to give you this question as well. It's not exactly the question that was phrased on the chat, but I'm going to switch it a little bit because we have had this discussion, and is how to select between a TCA or duloxetine or SSNRI. What is your criteria to select one or the other to treat chronic pain?
I would look at like patient's profile and patient's history as well. Like if your patient, and also side effects. So we talked about like TCAs have more side effects compared to SNRI, but at the same time, they're more effective on pain. Like if you prescribe nortriptyline might be more effective compared to Cymbalta on neuropathic pain or myofascial pain, but at the same time, there is higher like level of side effects. So I would just look at like the whole picture of the patient. If patient has some stress or anxiety, a little bit of depression, and has chronic myofascial pain, maybe Cymbalta would a good choice, like not going with a lot of side effects. At the same time, the SNRI also work on anxiety and depression as well, in addition to the pain. So it depends, like the patient's profile. Also, we can check like the kidney function, the liver function, like gabapentin metabolism is through kidney. So we want to make sure kidney is functioning well. Many of anticonvulsants are through liver. So we want to make sure the liver function is fine. So we look at the whole picture, and then we decide, we talk to the patient about possible side effects. And then with patient's agreement and like looking at patient's picture, we decide to which one to go.
Very good. This one is for Jouliana. Jouliana, what are your thoughts about adding steroid to lidocaine when you perform a trigger point injection?
So if it's the big muscles, it's possible, but we don't use for the master, especially facial muscles. We don't use the steroid, but steroid can be a choice for people like the trap. They can use it. And if it's a nerve injection, so that's a good choice. But for facial, we prefer to go the less side effects, or especially for the any injuries to the muscle or the face, because aesthetic wise. So that's our concern. But other than that, yes, they are using some for the different muscle if it's very painful, if there is inflammation involvement, so they can use for the bigger muscle. But for the facial, we prefer to go simple.
I'm going to chime in as well. Remember that we're treating a specific condition. So if you're treating inflammation, it makes sense to add a steroid, or it makes sense to prescribe an NSAID. But if you're treating a taut band, an area that is producing a trigger point, what we try to do with the trigger point injection is an interruption, it's a disruption. It's actually causing a local injury. So even a dry needle with no anesthetic will work if that is the mechanism. If we're treating a trismus because the patient has a contraction, you can inject as many trigger points as you want. That is not going to work because it's a different mechanism. So the selection of what we're going to put in the syringe has to be related with the diagnosis that we have made and the mechanism that we think is involved. So it's not common to add an steroid in a triggered point injection because we don't think that the trigger point is an inflammation, it's a local inflammation. But it makes complete sense to do a steroid injection if you are treating a local inflammation. There are other conditions such as some of the neuropathies or arthralgia. That's a different story, because on those cases it does make sense because you are treating that, but not for a trigger point injection. I think I covered all the questions that we had here. There was another one, and Jouliana, you started mentioning it. I think you knew that this question was coming, but let's go ahead and make a more comprehensive comment about, does a NIGARD have an effect on muscle contraction? If the only condition that the patient has is muscle pain, does it make sense to use a NIGARD? What is your criteria to deliver or to select a NIGARD in cases with myogenous pain? Not considering arthralgia or dislocation or clicking, that was one of the questions, but for myogenous conditions.
Yeah. So again, as I mentioned, if the patients mention, I have a clenching, I have a grinding, and they wake up in the morning with very tense tension, pain or discomfort of their muscles. So if they are mentioning that, and they are mentioning, I have a kind of headaches goes with that. So that's, I go with the night guard because I know the night guard, it can help them. It doesn't stop the grinding, of course, but it's kind of prevention of that tooth structure to kind of not losing the tooth structure. And also it gives them some relaxation. They are not holding very tight on their bite, especially they are not squeezing their teeth. That's helping them, especially the muscle and the joint in a good position they should be. It's kind of, and also I cannot tell it's the permanent solution for the grinding, but we see for some patients it works for a long period of time. That's how their body and nervous system kind of if there are something new in their mouth, they change differently, they act differently. So that's our stimulation kind of treating the muscle, treating the teeth, treating the nerve. Okay, stop whatever you're doing. It can be temporary, but for some patients, they get benefit and they love their night guard, they're using for many, many years. For some patients, it's just a temporary, they use it and it doesn't work. It's their body, how it reacts to that. But this is, we most give them for for their teeth structure, to holding their teeth structure, not losing the teeth structure. Other than that, it just something trick the body. That's how we are using that.
Modulation, biofeedback, huh? There was another question that we kind of answered, but I'm going to go over that again. And it is, will medications such as Cymbalta or duloxetine produce dry mouth? And I just want to comment that for pain purposes, the doses that we use of TCAs and SSNRIs are not as high as the doses that are required for depression, anxiety. So because of that, it's not that common that we will have as a side effect dry mouth. It is possible, especially with the TCAs, that the patient will feel saliva a little bit thicker, and that is possible. But in those cases, we ask the patient to increase water intake. That anyway is a good idea. But the doses that we use are usually not that high. Like with duloxetine, we rarely go over 60 milligrams. With nortriptyline, we're usually 40 milligrams max, and with amitriptyline, we're usually 50. So it's rare that we will have dry mouth on those cases.
And Dr. Padilla, I want to mention sometimes they have a question, especially with the cyclobenzaprine Flexrid. If they want to use that one, that's for a more acute pain the patient has, and they shouldn't use for a longer time. If they want to use for the longer time, that's the moment. We are using maybe 2 weeks, maximum 4 weeks, with very low dose, maybe 5 milligram, 10 milligram at night. And then if you want to continue for another month or two, we switch to TCAs, which again is a low dose, less side effects for the patients because we are just treating their muscle pain, nothing else. So that's, if they have a question, kind of, I hope we answer that side too.
Yeah, thank you, Dr. Jouliana. We have a question from Dr. Ando related on strategies or research going on for treatment of a sleep bruxismo. So basically, counter stimulation is very strong right now. We're talking about vibrational splints. We're talking about changing the behavior of the patients. There is no magic cure for bruxismo at this moment. We are working on protecting the tissues, protecting the muscles, protecting the jaw. But one thing that we're looking into is the reduction or the counter stimulation through a feedback system for the patient to get awareness, not enough to wake up, but enough to stop the grinding or the clenching. And that's what we are at this moment. Other than that, you can look into the literature. Some people is promoting more the use of Botox, but that actually doesn't reduce the habit, reduce the force of the muscle. So, it's a combination of things. Okay, do we have any other questions? I think
don't
we
see
answered them
any.
all. Oh, there was a question that was in the chat, and I see that Dr. Ahmadieh answered it, but let's bring it to the group. What are the risks related with trigger point injection? So let's talk in general. What are the general risks? Not only not only vessel injuries, but in general, what are potential problems with injections of trigger points?
So for the amount and the muscle that we're injecting, it's very low, the side effects. But we have to make sure before we are doing any injections, we have to make sure and ask the patient if there are any infection, active infection, it's involved, or they are using any anticoagulant medication. If they have a bleeding tendency, they are easily bruising, they are bleeding, or any needling, afraid of needle, because you can see some patients, there is no way you can do the injection because they're afraid of the needle. So we have to consider those first. And then the side effect, again, if they are using aspirin is not a concern at this moment. But if there are like other medications, we have to ask them, consult with their physician, and then if they have to stop, if they have to reduce. But again, the amount that we are injecting and the needle is very thin. They shouldn't have any bleeding or any bruising. But again, we have to consider those. It can be infection after the injections. However, again, if you're cleaning very well and there is nothing on the face, then they shouldn't have infection. Otherwise, they're gonna have infection. Or they can have some little bit of the bruising or redness. Of course, if they have a lidocaine allergies, we have to ask them before. Otherwise, you're gonna see all this redness because of the allergy. But that, again, it's very rare, but you have to ask. Those are the things that they might have.
I think you mean
have this.
That the vasomotor response, vasovagal response, a patient who gets a low pressure and then they feel dizzy, and so that's another possibility. We have had
and
some
sometimes
of those.
If they are scared, that's how they get there. So we have to consider everything. We have to talk about that, show how we are doing, and explain everything before we do any injection. Other than that, it's very low chance of getting the side effects, honestly. But again, for everything, you have to consider if something happened, what is my strategy, what I should do to stop the side effects. And especially if you're giving them the cold pack, it's kind of reduce the inflammation, so it helps them.
Correct.
So yeah, so those
very
are
nice. Now, when you do the injection in a muscle, you have to kind of feel the thickness of that muscle. So you ask the patient, if you're going to do masseter, you ask the patient to clench first, and you kind of feel to see how thick that muscle is. And you have to be sure that the needle goes beyond the epidermal layer. So you have to be sure that you're in the muscle. So how deep you go depends on the muscle and depends on the patient. So it is very difficult to say 0.5 or 1 centimeter. I will say that very rarely less than 1 centimeter, because you have to skip the first layer of the skin. In other areas, in flat muscles, such as the temporalis muscle, the bone is over there. So very fast you will hit bone. So you don't really want to hit bone for two reasons. One is that you can produce a little bruise on that area that might be a little painful later, but also because the needle will be dull, will be, it will change a little bit the way that the liver or the liquid will behave. So you try not to touch the bone, but you try to get a sense of the thickness of the area that you're going to inject. And the best way to do that, and if you haven't done one, I recommend you start with masseter muscle, just the patient to clench. And when they clench, you feel to see how bulky that muscle is, and then you do your injection. So it depends. I'm sorry, we don't have a magic number of how deep the needle has to go. What it is important is you don't want a big gouge. You want 26, 27. So you produce a very minor interruption or disruption of the skin, but you have a needle that will not bend easily. One tip over here, when you do dry needling, you don't want acupuncture needles that are too thin because they bend too easily. So you want to be able to have a needle that is sturdy enough to allow you to do the needling, the salt and pepper, but we don't want one that is too thick that will produce a hole on the skin. So the answer is depends on the muscle that you're going to inject and depends on the patient itself. Is Mirogabalin, a gabapentinoid, available in the United States? I haven't heard about it. I'm not sure if it's available or not. So we don't have impressions yet. So we will be looking forward your own impressions. I will take a look to see. What it is interesting, gabapentin and pregabalin, the difference, one of the main difference between the two is the amount that you have to give to reach therapeutic levels. So with medications such as pregabalin, after the second dose, you're very close to therapeutic levels. That doesn't happen with gabapentin. You have to give more. So if you want a slow titration, you want a medication that allows you to do that. That's why I like gabapentin a lot, because it allows me to go slowly. But if you're in a hurry to relieve that patient and the patient doesn't mind the potential side effects, pregabalin works better. This new medication that is mentioned on the chat, I haven't heard, but it will be interesting to see how it behaves. Thank you for bringing that up. Okay, I think officially 8:45, we wanted to finish at 8:50. So I think we are ready to do our closing remarks. What would be your advice to the people who's here with us regarding myogenous conditions? What do you think is a pearl, a take-home message that if you want for them to only remember one thing of everything that we talked today, what would that be, Dr. Ahmadieh?
If it is like one thing, as I said, like if you think of non-odontogenic pain, the first thing you think of would be myofascial pain. So always rule out myofascial pain.
Thank you. Dr. Davoudi, what is your pearl? What is your advice for the group?
My advice is always have the diagnosis first and then treat based on that, and also have your backup plan. So you have to show your patients you are capable and you know what you're doing.
Thank you. My advice will be to keep learning, keep coming to presentations where you are exposed to different scenarios. The Armenian American Medical Society has a lineup for you during this month. We are very happy to participate with 4 lectures. We have a lecture on neuropathic pain and a couple of lectures mostly related with oral medicine. And we had a great attendance today. We hope to see all of you on our next presentations. So thank you very much, everybody. Remember, the key word is Ostro Online, 2 separate words, Ostro Online. Also remember that you have to complete a quiz in order to get your CME. And thank you very much to the organizers to invite us today.
Thank you. Have a good night.
Thank you.
Bye-bye.